Can you ever imagine that a cancer of the genital tract in a female can present with excessive white vaginal discharge? Well, when you think about cancer, you will always think about necrotic tissue, bleeding, pain, and maybe purulent discharge, foul smelling discharge. But can simply white excessive discharge present as one of the cancers in the uterus? Well, yes, it is one of the cancers from the uterus, and uterus itself is such a mystical organ. It can present with three, four different types of carcinomas. It can be the mouth of the uterus, that is cervical cancer. It can be the body of the uterus, that is endometrial cancer. It can be the fallopian tube cancer, that is a different entity, and ovarian cancer. So one particular organ, genital organ in the female can present with so many different cancers. So today's topic is endometrial cancer, a very unique sort of cancer, which is not as common as the cervical cancer, but again, it is quite common when you actually start the day-to-day practice. So this is a cancer which can present with excessive white vaginal discharge. So even if patient comes with only one complaint, you should be suspicious that there may be some carcinoma sitting there. Okay, so coming to the topic, endometrial cancer. Now, before we talk about cancer, let me tell you that there is always a precursor for cancer. Just like in cervical cancer, in endometrial cancer, the precursor would be endometrial hyperplasia. That means very, very thick endometrium, and this is normally diagnosed by ultrasound. The patient will come to you with different types of menstrual complaints, polymenorrhea, it may be metrorrhagia, it may be intermenstrual bleeding, it may be postmenopausal bleeding. So in that case, obviously the first investigation will be ultrasound. When we do an ultrasound, we see that the endometrial lining is very thick. Now, what is the cutoff? In a postmenopausal woman, the cutoff is generally 5 millimeters. So if the patient is postmenopausal and the endometrial thickness is more than 5 millimeters and she's having the complaints of dysfunctional uterine bleeding, you do an endometrial biopsy. In a in a premenopausal lady, a lady who is already menstruating, if she comes with these complaints and she's perimenopausal, above 40, generally above 40, clinically we don't do an endometrial biopsy unless indicated, really indicated. We don't do it before the age of 40, because before the age of 40, she's in the reproductive age group and she might be having all these alterations of endometrial thickness. We have read this in the chapter on menstrual cycle, how the thickness of endometrium, it changes from 3 millimeter just post menstrual to almost 11 to 12 to 15 millimeters premenstrual, right? But the normal the range which is given in your textbooks, according to the pathologist or according to the gynecologist, what to actually follow. If the patient comes to you in with complaints of dysfunctional uterine bleeding and she's around 40 or above 40, perimenopausal age group, then the normal cutoff is 12 millimeter. So if it is more than 12, you should tell her to go for a biopsy, because less than 12, you might not get any endometrial tissue if you do a biopsy. Right now, the what kind of different reports, pathological reports you can get. Now, simple hyperplasia without atypical cells. It may be cystic glandular hyperplasia, the kind of almost similar. That is excessive proliferation of the glandular tissue, the endometrial tissue, without any atypical or dysplastic cells, right? So this can be one diagnosis. The chances of malignancy in such cases is only 1%, right? The second can be complex hyperplasia, again without atypical cells. Now, because it is complex, the arrangement of the cells is different. It is not simple, it is complex. So the chances of malignancy will be slightly higher, but still very low, just about 3%. So both these cases, simple, cystic, and complex, because they do not have any atypical cells, they will be treated with medroxyprogesterone acetate, which is generally given 10 milligrams 3 times a day. That is why it is written 30 milligrams or maximum 40 milligrams a day. Right, and this can be given in a cyclical manner. For say 25 days, you give the tablet, tell her to stop for the next 7 days so that she has her period, and then again start in the next cycle. So that is 25 plus 7 or 21 plus 7, depending upon the doctor's choice and depending upon how much she's bleeding. Depending upon how much endometrial hyperplasia she has, you can alter the dose to 20 milligram or 30 milligram or 40 milligram. Okay, and you have to give this for at least 3 to 6 months. Repeat a biopsy again after 6 months or maybe after 1 year, depending upon her symptoms. The other option of treatment can be Mirena coil. So as I told you, Mirena coil is a levonorgestrel IUS system, that is intrauterine system, which is just in the shape of a copper T. So it looks like a copper T, but it is not copper. It is impregnated with progesterone, that is levonorgestrel progesterone. The limb contains the progesterone and it has a tail which obviously hangs in the vagina. So it looks like a copper T, and it is slightly costlier than the copper Ts, the normal multi-loads available in the market, because it has progesterone inside it. So the purpose is that you put this coil inside the uterus, and then it will act locally, and it will be releasing around 20 micrograms, very little quantity of progesterone every day in the body. So within a couple of weeks, within 2 or 3 months, the patient's endometrial lining will be completely dried up, and she might end up in amenorrhea, and the symptoms will be relieved. Okay, so these are the two treatments which are available for hyperplasia without any atypical cells. The next diagnosis will be simple hyperplasia or complex with atypical cells. Now, simple and complex can also have atypical cells, and of course, the chances of malignancy in such cases will be higher as compared to the ones which is without atypical cells, right? So the simple will be 10 to 20%, and complex will be 60 to 70%. In such cases, obviously, the treatment will be total abdominal hysterectomy with bilateral salpingo-oophorectomy. So you do not wait for this to change into a complex hyperplasia. You just tell her that you have atypical cells. We cannot wait. Sometimes if the patient is not fit, in cases of simple hyperplasia with atypical cells, sometimes you can give her depot medroxyprogesterone acetate, which is a high dose progesterone injection. Give her for 3 months, because it is basically an injection which stays for 3 months. The validity is 3 months. So you give her one injection, and then after 3 months you can repeat a biopsy. But that is something very, very optional, depending upon the patient's choice and your own prediction as to what is going to happen, depending upon patient's profile as well. But generally, when there are atypical cells, you will always advise her total abdominal hysterectomy, remove the uterus along with the tubes and ovaries. Coming to the endometrial cancer incidence. Now, the incidence, it is highest in the whites, lowest in India and Japan. So, India is basically leading in cervical cancer, but not endometrial cancer. Why endometrial cancer is more common in the Western world, in the whites, we'll come to that. Okay. It ranks third amongst the genital malignancies in India. So, why third? Because first is cervical, second is breast. Sometimes breast becomes first and cervical becomes second. So, it is always cervical cancer and breast cancer in the top two leading cancers of genital tract or of female cancers. And the third one is uterine cancer, that is the endometrial cancer. Now, why the incidence in whites is higher as compared to the developing population? That is because due to high expectation of life. Now, they expect a lot from their life, especially in the postmenopausal ladies. They would like to stay alone. They would like not to take any help from the children. They would like to be very independent, and because of the menopausal symptoms, they might suffer from a lot of hot flushes and many other problems. So they end up in menopause clinics, and they end up having high dose hormone replacement therapies. I have worked in UK for 4 years, and there was a separate clinic for the menopausal ladies, and the kind of women I have seen, they really have a lot of symptoms because of their you can say the social background, the kind of diet they have, the kind of social security they have. The culture is different, so basically they suffer from a lot of depression and a lot of menopausal symptoms, so they end up taking HRT, which predisposes them for breast cancer and endometrial cancer. The second reason is because of awareness in such women in the developed countries. Obviously the awareness for cancer is too much, so they pick up the cancer very soon, and that is why the incidence is higher in white population, because they are under always screening programs. There are lots of screening programs and prophylactic screenings going on. So the detection of cancer in such women is more as compared to the developing world, where we don't have any effective screening programs. All right. What are the etiological factors or the risk factors for developing endometrial cancer? Now, it is very obvious when the endometrium is growing, that means estrogen has to be there. Estrogen will actually make the endometrium hyperplastic. So any condition, any kind of tumor which is releasing a lot of estrogen in the body is going to predispose this lady for endometrial cancer. So it can be feminizing ovarian tumors, or it can be simply high dose or long-term HRT, hormone replacement therapy. The second thing is early menarche and late menopause. Obviously, if the menarche came at 9 or 10, so that means the estrogen stimulation of the uterus started very early in the age, and late menopause, that means she has been under the estrogenic stimulation for a long time. Low parity. Now, why low parity? Because she has very few episodes of amenorrhea. Now, parity means obviously when she has gone pregnant for the 9 months, she will be amenorrheic and the estrogen stimulation will be less. But if low parity, just 1 or 2 children, and she has been constantly menstruating every month, so obviously there was a lot of estrogen stimulation. Ladies who have lots of childbirth, multiparity, the cervix will be damaged. They will be more prone towards cervical cancer, but it will be protective for endometrial cancer. So they are kind of opposite to each other. Low parity is a high risk factor for endometrial cancer. High parity is high risk factor for cervical cancer. Okay. Corpus cancer syndrome. Now, there is a profile of the patient which is very, very common in when you start practicing. You will see generally these patients are obese, hypertensive, and diabetic, and that is known as corpus cancer syndrome. That is generally present in 30% of the endometrial cancers. So that is obesity, hypertension, and diabetes. They go hand in hand. They predispose the patient for endometrial cancer. Then obesity. Why obesity? Because within the fatty tissue, the androgen gets converted into aromatized into E1, that is estrone, and that gets converted into E2, right? And that predisposes a woman to endometrial cancer. Chronic anovulation and PCOS, because these patients are continuously under unopposed estrogen stimulation. Tamoxifen, again, it is an anti-estrogen as well as estrogenic compound. So it is an aromatase inhibitor, and it is used for cancer patients, breast cancer patients, but it can also have estrogenic properties. So long-term use of tamoxifen can make them a high-risk patient for endometrial cancer. Then family history of endometrial cancer. HNPCC is hereditary non-polyposis colorectal cancer. This has been linked with the BRCA gene, which is there for breast cancer and colon cancer, and also predisposed for endometrial cancer. So three types of cancer, they go hand in hand with this kind of syndrome. One is colon cancer, one is breast cancer, that you will read in the surgical lectures, and one is endometrial cancer, right? So these three cancers, they go hand in hand, and quite hereditary characters, because you will see that the patient has a hereditary history, colon cancers and breast cancers and endometrial cancers, because of this particular syndrome. Then fibroids, they may be associated in 3% cases with endometrial cancer. Fibroid can undergo sarcomatous change, and that is also a kind of endometrial cancer. Endometrial hyperplasia, obviously we've read that, especially the complex with atypical changes, and radiation menopause. Okay, so the patient has had radiation for some kind of other cancer or some other reason, and she ended up in having problems in the endometrium and cancerous changes in the endometrium. Then coming to pathology, how does the actually uterus look like in a gross condition? Uterus is small, normal, or enlarged. Okay, it may be very small, so it is not that the cancer is growing, so it has to be big. It can be small, it can be slightly bigger, or it can be very, very big. Okay, now why they are big? When this endometrial cancer invades into the myometrium. So myometrial involvement, that causes myohyperplasia and pyometra. Sometimes because of the involvement of the myometrium, there is a lot of pus accumulation, which accumulates within the uterus. It does not drain because of whatever reason. It might be because there is cervical stenosis, or maybe it's a menopausal lady, the cervix is not open up, and it might be associated with associated fibroid. So these are the causes which can cause the which can make the uterus look big and enlarged and bulky. Otherwise, generally it might be a small or a normal size uterus, because it is just the endometrium which is showing cancerous changes. There's nothing to do with the myometrium. Then what are the varieties? There are two varieties. One is localized and the other one is diffuse. The localized endometrial cancer will be usually on the fundus. Generally, it is seen on the fundus, or it can be on the lateral walls as well. It may be sessile or it may be pedunculated. Now, this is something which I have never seen. It is generally sessile, because obviously sessile means it doesn't have a pedicle which makes it hang. Because cancers will definitely not hang. It will be mainly the fibroids and the polyps which will hang. But sometimes you never know. It might be a polyp which has turned cancerous. Okay, so it might be just hanging inside here. So that's the uterus, that's the endometrium, and that's the myometrium here, right? So the endometrial tissue, that's the endometrial tissue, and there may be a localized cancer which is hanging. It is just hanging like this, and this becomes cancerous. So this shows cancerous changes. So this is a kind of localized endometrial cancer which is not sessile. It has a pedicle, that is a pedicle and peduncle. Okay. Then myometrial involvement is late. In such cases, myometrial involvement is late in the localized cases. In diffuse cases, the spread is through the endometrium. Diffuse means the entire endometrium, or very good amount of endometrium is getting involved. Myometrium is commonly invaded in such cases, and it may invade to reach the serosal cord as well. Okay, so the difference between localized and diffuse, the diffuse one will have more chances of involvement of myometrium, and it might go up to the serosa. Now that we will learn in the staging, how we stage it. And the localized one will generally be restricted to the endometrium. Myometrial involvement will be later or very less. That's the diagram showing you the difference between generalized and localized. So you can see localized, it is not actually at the fundus, it is one of the lateral walls. And this is generalized, it is actually diffusing through the myometrium and might reach the serosal coat. That's again another photograph of endometrial cancer. You can see the uterus is just a normal size. Everything looks normal. It's only when you cut it, you can see this necrotic tissue inside. And this can be easily picked up sometimes with hysteroscopy. Okay. Now, the microscopic appearance will be of different varied types depending upon what kind of changes the endometrial tissue has gone through. The incidence of adenocarcinoma endometrioid type is 80%. So, 80% will be endometrioid types, that is proper endometrial cancer. Then adenocarcinoma with squamous elements, that is known as adenoacanthoma. So that means the endometrium, which is actually columnar epithelium, it also shows some squamous elements within it, that is adenoacanthoma. Papillary serous carcinoma is just 5 to 10%, which is kind of very dangerous type of cancer. Mucinous adenocarcinoma, just 2%. Clear cell, again a very dangerous one, less than 5%. Secretory carcinoma is 1%. Squamous cell, purely squamous cell carcinoma of the endometrium, very, very rare, but it has been seen, okay? Because we expect that the endometrium obviously has columnar cells, so why should we have squamous cell carcinoma there? But it has been seen and reported, okay? Mixed carcinomas can be there and undifferentiated carcinomas, which are just 1 to 2%. So mainly it is endometrioid types, which is proper endometrial tissue undergoing cancerous changes. Now, coming to the classification of endometrial cancer, this was the histological classification. Now, coming to the biological and histological behavior, how they behave. So, depending upon that, it is type 1 and type 2. Okay, you should know the differences. So, the first difference is the risk factor. It is generally because of unopposed estrogen, and this is not because of unopposed estrogen. It is generally the age related. Okay, so it is generally in the postmenopausal women where the estrogen is less. Now, the age profile, if you see in the type 1, because it is unopposed estrogen, so obviously it has to be the perimenopause age group, not after menopause. This is the opposite, it is in the menopause age group. Now, endometrial hyperplasia will be present here because it is estrogen dependent. It will not be showing any endometrial hyperplasia. Tissue differentiation it will be well differentiated. The young age women will be having estrogen dependent, well differentiated carcinoma. This one will be poorly differentiated, not dependent upon estrogen. Myometrial invasion here will be minimal. That is why it has good prognosis. This one has a deep myometrial involvement. That is why it has a bad prognosis, and the tissue differentiation is also poor. Okay, so this one type 2 is more dangerous. Histological, this will be endometrioid, that is purely endometrial cancer. This one will be either serous or clear cell. As I told you, both are very, very dangerous. Grade, this one will be adenocarcinoma grade 1 or 2. Okay, so it will be grade 1 or 2. We will come to the grading. What does it mean? It is actually the arrangement of the cells, grade 1, 2, 3. So when it becomes worse, it goes towards grade 3. So this one will be adenocarcinoma of grade 3 type of the serous and clear cell type. Okay. Races, if you look at the race, the white females are more prone to have the type 1 because of excessive use of estrogen, because of a lot of expectation from their life. But this type 2 is generally in the black females, and they are obviously not, this cancer is not dependent upon estrogen. It happens in the postmenopausal age group. So it is kind of the same age group which happens in the cervical cancer. And this one is more dangerous. More invasion of myometrium. The histological differentiation is poor, grade 3, and the type is serous or clear cell. Then coming to the molecular characters, if you look at the polyploidy or the ploidy, this one is polyploid, this one is aneuploid. So aneuploid is obviously more dangerous. There are certain expressions of certain mononuclear characters, that is HAR2 and NEU overexpression. Here there is no such expression, here there is an expression. So you just need to memorize what these are, the names. These are certain biochemical markers which the oncologists and oncosurgeons will use, and the pathologist will be able to do this biochemical staining of the tissue, the biopsy tissue, which we receive after doing a DNC or hysteroscopic biopsy that we take. And after that, after getting this kind of picture as to whether these are expressed or not, we will decide whether she needs, after surgery, does she need any chemotherapy or radiotherapy, what kind of cancer it is, how aggressive it is. This is how it is detected. Okay. Then P53, again, it's a molecular marker. It is not present here, but it is present here. PTEN mutations are present here, but they are not present here. So this is something which is a yes here, but no here. Apart from this, all are kind of having yes in the type 2, but no in the type 1. Okay. Prognosis, obviously, it is very obvious, favorable, and this is not favorable. So, type 2 endometrial cancer, which happens in the postmenopausal age group, which is not estrogen dependent, is very, very bad prognosis because it is serous cell, clear cell, not endometrioid. It doesn't have any hyperplasia. It has lots of molecular markers which are present. It is aneuploid. It is expressing many molecular markers, and it is in the black women, very common in the black women. Okay. Next, coming to the grading, how it is graded into grade 1, grade 2, grade 3. Any cancer, according to the differentiation, the glandular architecture, and the anaplasia of cells, will be classified into grade 1, grade 2, grade 3. Depending upon that, the oncosurgeons and oncologists, they decide the further treatment. Now, grade 1 will be glandular pattern is maintained, cells they show atypia, and less than 5% are undifferentiated cells. Okay, so only less than 5% are undifferentiated, otherwise they are all well differentiated, glandular pattern maintained with cells showing atypical changes. Grade 2 will be, some will show papillary pattern and they are solid, and around 50% will be undifferentiated cells. Okay, so from atypical changes, they will now show papillary patterns. Grade 3, they will all be almost solid with cellular proliferation. There will be a loss of glandular architecture, the way the glands are arranged. There will be little stroma, and more than 50% will be undifferentiated cells. Okay, so that is the one which is normally seen in type 2 endometrial carcinomas, and this is the most dangerous one. Okay. Then the spread of endometrial cancer. How does it spread? Now, the ways of spread are always either direct, lymphatic, hematogenous, or there is a direct implantation. Now, the direct spread will be, first of all, it's a slow growing tumor. Now, as I told you, the localized one will be slow growing and it will just be localized to the endometrium. The myometrial invasion will be slow and late. In the diffuse one, it might invade the myometrium quickly as compared to the localized one, but still it is in general a very slow growing tumor. It may gradually infiltrate into the myometrium and spread to the parametrium. So it can infiltrate either from here, it can infiltrate, or it can infiltrate from here. Okay, so if it goes from here, it will go into the parametrium. That's the parametrium here. And if it goes from here, then it is actually invading the serosa and going outside the uterine body into the pelvis, the true pelvis. Now, peritoneal cavity, it can also invade through the peritoneal cavity, through the tubes and downwards to involve the cervix in 15% cases. So that's the tube here and that's the cervix here. So the direct spread can be through the tubes, through the serosa, it can go into the parametrium. This can actually go into the peritoneal cavity. This is also going to the peritoneal cavity. And again, this here will go directly to the cervix. Okay. Now, commonest local metastasis will occur in the vaginal vault. So that's the vaginal vault, and in 15% of the cases, the cancer might spread here. So the commonest local metastasis, you can say the direct metastasis, that it is actually spreading from the cancer. The cancer is actually coming down in the cervix and then coming to the vault. This is the most common local or direct metastasis of endometrial cancer seen in 15% cases. The next type of spread will be lymphatic. Again, it is usually late because it's a slow growing tumor. Now, what are the lymphatic channels that are associated with the uterus? They are common iliac, the internal iliac, external iliac, and then later on the superficial inguinal. Okay, so pelvic lymph nodes, and then later on they can go to the common iliac and paraaortic. So paraaortic lymph nodes, rarely inguinal and femoral lymph nodes. So that happens very, very late. The chances of lymph node involvement will depend upon the stage where the cancer is, whether it is in the endometrium or in the myometrium, or it has invaded into the cervix. Stage 1, stage 2, we'll come to the staging very soon. And it would also depend upon the type of grading, grade 1, grade 2, grade 3. So in stage 1, when it is restricted to the uterine corpus, that is endometrium and myometrium, it can be 4% if it is grade 1 and 2, but it can jump to 40%, 10 times more when it is grade 3 differentiation. Okay, that is a very fast growing tumor. Then stage 2 will be 40% chances of lymph node involvement because it has come down to the cervix. Tubes and ovaries involved in 3 to 5% by direct or lymphatic. So the tubes and ovaries are quite safe in endometrial cancer as well as cervical cancer. In cervical cancer, the involvement of ovaries is just 1%. Okay, so in endometrial cancer, tubes and ovaries involvement is just 3 to 5%. That can be direct extension or it can be through lymphatics. Vagina involvement is 10 to 15%. As I told you, direct implantation, direct extension of the cancer into the vagina is quite common, and that is around 15%. Vault metastasis after hysterectomy, direct or lymphatic. So if you have removed the uterus and there was some cancerous change in the endometrium which got missed, maybe after doing the surgery, the pathology department will tell you that there were some cancerous changes, and at that time, the vault, the vaginal vault, which has been probably impregnated with some endometrial cells, or there will be some spilling when we do the hysterectomy. So direct metastasis or through lymphatics, it can come down to the vault. Okay. Next type of spread is hematogenous, and it is generally late, it goes to the distant organs. So in the pelvis, whatever cancer it is, cervical cancer or endometrial cancer, there are two main kinds of extensions. One is direct and the second one is lymphatic. Hematogenous comes very, very late when it goes into the stage 3 and stage 4, that is distant metastasis. Okay, and the common sites are lungs, liver, brain, and bones, very much like cervical cancer. Now, what are the clinical features? As I told you, endometrial cancer, cervical cancer, they are basically related to uterus. So they will present with abnormal bleeding, filthy discharge, foul smelling discharge, watery, bloody discharge. Now, watery discharge is something you have to be very careful. We have seen many cases and they have been reported in the journals that excessive white discharge can be the only symptom in endometrial cancer or even fallopian tube cancer. Okay, so excessive white discharge with no other symptom, and you cannot make out why she's having hydroria. Hydroria means excessive white discharge. Then you have to suspect this. Then painful intercourse. Yes, if the pathology is there in the uterus or in the cervix, and during intercourse, obviously that will pain. And pelvic pains or cramps, because there is some pathology going on within the uterus that can cause crampy movements of the uterus, the kind of Simpson's pain when the uterus tries to push the abnormal tissue out. It can happen in polyps, it can happen in fibroids also. Okay. Now, the patient profile generally, as I told you, nullipara, because low parity or nulliparity predisposes the patient towards cancer because she never had or had very few episodes of amenorrhea. Then obesity, yes, the fatty tissue converts androgen into estrogens. Diabetes and hypertension, that's a copper cancer syndrome. And postmenopausal, she can be one of the ladies who is in the postmenopausal age group. History of delayed menopause. Now, as I told you, early menarche and delayed menopause are one of the profiles, one of the high risk factors. Postmenopausal bleeding in 75% of the cases. Premenopausal women will have irregular excessive bleeding. Obviously, the menstrual symptoms will differ from lady to lady. Watery offensive discharge due to pyometra. Now, if it is pyometra, it will be offensive. Otherwise, it can be simply clear excessive watery discharge. Pain, colicky pain, that is Simpson's pain because the uterus tries to push the tissue from inside out. Hydroria is excessive white watery discharge. Pelvic pressure in late cases when there is a big mass developing, then she'll have pressure, and less than 5% will be asymptomatic. So why less than 5%? Because uterine cancer as such presents very quickly because it is within the body of the uterus. So there will be some symptom which will make the patient go to the doctor, and if the doctor is vigilant and they investigate the patient properly and the patient is also compliant, she actually listens to the doctor and obeys what they're telling, then obviously this can be picked very quickly and it has good prognosis because it presents early, unlike cervical cancer which presents almost in the third stage because of lack of awareness and because of many times it is quite asymptomatic. But this one is only less than 5% are asymptomatic, otherwise they will present with some symptom. Okay. Now, varying degrees of pallor. What do we actually see when we examine the patient? They might be pallor anemia because of excessive bleeding, blood or pus coming out from the external os. That is very, very indicative there is some pathology within the uterine cavity. Per vagina, there may be an enlarged uterus or a normal size regular uterus. It will be a regularly shaped uterus, very much like adenomyosis, because fibroids they make it irregular, but the cancer or adenomyosis makes it quite regular. Examine the regional lymph nodes if possible and breast as well if you're suspecting HNPCC and BRCA gene presence in the family. HNPCC is hereditary non-polyposis colorectal cancer. Okay. Now, how do we diagnose? What are the markers that we do? Cancer antigen 125. Now, that is something which we do for endometrial cancer. Like for ovarian, it is CA125. Similarly, the same antigen here is cancer antigen CA125. If elevated, it indicates advanced disease. So, it is a marker used for ovarian cancer. It is a very non-specific marker, and it is even raised in endometriosis whenever there is endometrial tissue outside the uterus. So, it is related to ovarian cancer, endometrial cancer, endometriosis, whenever it is elevated, it suggests some pathology. And in cancer, obviously, it will be more than 250. Okay. Pap smear, it is not very reliable because sometimes the pap smear might pick up some endometrial cells which are present in the cervix, just shed off in the cervix, and the pathologist has picked up those cells and they tell you that there is an endometrioid type of cancer. So positive only in 50% cases. Endometrial cells, they reveal large round cells. So difference between endometrial cells and the endocervical columnar cells, the pathologist knows that. So you should know that endometrial cells will reveal a large round cell with dark nuclei filling most of the cells. So if you look here, these are the cells you can see, and the nucleus is so big, it is almost filling the entire cell. So if this is the cell here, that's the cell here. So you can hardly see any cytoplasm because the entire cell is full of this dark staining nucleus. Okay. Then what is the other test? Endometrial biopsy. Obviously, it is the gold standard for any cancer. Biopsy is the gold standard investigation. All others are just indicative. Ultrasound, obviously, you know that in a postmenopausal women more than 5 millimeters, and premenopausal if it is more than 12 millimeter in a perimenopausal age group, and suggesting symptoms are there, then you should go for a biopsy. Thickness more than 4, hyper-echoic endometrium with irregular outline. Now, so normally the endometrium will show a thin line or a triple line sometimes when it is in the ovulation phase. So that's the kind of endometrium we get. If in the uterus, that's the normal picture of endometrium that we normally get. But if it is irregular and it is showing a shaggy outline, that is, it is irregular and it is hyperechoic, that is excessively whitish appearance of the tissue, that is the language we use in ultrasound. So that is hyperechoic. That means it is some suggestive of some pathology and it needs a biopsy. Increased vascularity, you put a Doppler study, you see the vascular pattern of this particular tissue, and you see there is increased vascularity and there is some fluid inside. So basically the fluid will look like a blackish appearance within the ultrasound. You will see that the endometrial tissue is whitish and in between there is a black shadow, just like a lake inside. That will suggest that there is some endometrial fluid and she will need a biopsy to check what is happening. Okay. Hysteroscopy, obviously, hysteroscopy is very helpful. You put a hysteroscope and a gynecologist who is trained enough, whose eyes are trained enough to check what is a normal endometrium, what is an abnormal endometrium. She might pick up localized areas of maybe cotton wool appearance or some pathological endometrium which does not look normal. Okay, so direct visualization, and then we can do a target biopsy. We put a scope from here and then we check that wherever the cancer is, say for example if it is here, we can just put a forceps and take that biopsy instead of just doing a blind dilatation and curettage and doing all kind of biopsy from everywhere. You just pick up that particular tissue. Okay, that's the diagram I just showed you. That is the kind of endometrial appearance of the cells which might be picked up in pap smear or in the biopsy. Now, how do you do biopsy? For endometrial biopsy, you don't actually need to take the patient to the OT and put her to sleep, because if she has a good, you can say, a pain threshold, it might just take maybe 2 minutes to take a biopsy. These are the two kinds of biopsy instruments available in the OPD, in the outdoor, where you do not need to put the patient to sedation or to sleep. So this is known as PIPEL. This is a PIPEL forceps, or you can say a PIPEL curette, PIPELLE. Okay, so that's a PIPEL, and this one is known as Carman's cannula. This one is a Carman's cannula. It has teeth here. There are teeth which are not very visible in this. So that's a Carman cannula, and what you can do is you can just curette. It has teeth on the hole that I showed you. So you can just curette the uterine cavity with this particular instrument. It is metallic, and this might be slightly painful. You need to put the patient to sleep. But the PIPEL is very, very simple. It is just a simple plastic instrument. You put it inside and there is a syringe attached to it. So with just vacuum suction, you can suck some endometrial tissue, and this will just take 2 to 3 minutes. And it's very thin. You do not need to dilate the cervix also. So that is up to the doctor and up to the patient, and of course availability of these instruments in the OPD. If PIPEL is available and the patient is ready for without anesthesia biopsy, then you can try it in the OPD itself, and provided you get a good sample, that's fine. Otherwise, you take her to the operation theater, put her to sleep for 10 minutes, and then you can use this cannula or just a normal curette which we normally use for DNC. Okay. Now, what is fractional curettage? Fractional curettage is very commonly done for endometrial cancer. It is a definite method of diagnosis under anesthesia. So you have to put the patient under anesthesia, give her short GA or IV sedation. It can detect the extent of growth as well, because what you're doing is you're fractionally curating from different parts of the uterus. You're not just going blind. Okay, so for example, that's the uterus here, and we are suspecting cancer. So we will cure it from here, we'll cure it from here, we'll cure it from here. So we take different biopsies from different parts of the uterus and then label them. Okay, this is a fundal biopsy, this is right lateral, this is left lateral. This is how we actually label them separately. Okay, that's known as fractional curettage. So what we do initially, we do an endocervical curettage. Okay, we go here with the curate here, and then we do an endocervical. So we do an endocervical curettage, then we do sounding and dilatation, then we do uterine curettage at the fundus, then we do it at the lower body as well, that is the lower body here, and then we can do from the lateral wall. So we're taking different parts of biopsies in different jars. This is endocervical, this is up to the fundus, this is lateral wall, and this is the lower body of the uterus. So because we label them separately, the report comes separately, and then we know where exactly the cancer is. And if it is here and it has spread here also, that means we know it is extending. It is a generalized type of cancer. If it is here also, that means it is spreading. So we come to know exactly what is the stage of the cancer. Okay. Tissue will generally appear dark and good quantity. If it is a cancer, it will be a lot of necrotic tissue, and you will get good amount of tissue which can be sent for biopsy. Polyp forceps sometimes can be used. Polyp forceps are simply just forceps like this, which have a kind of rounded structure at the top. So you just open the forceps and it has a rounded kind of mouth, and you can just pull the forceps, the polyp out. So sometimes they can also be used if you are suspecting a polyp which has been diagnosed on ultrasound. And the specimens are sent separately. Obviously, that is why we are doing separate biopsies and separate jars for the biopsy. Now, you can do chest X-ray if you're suspecting chest or lungs spread. You can do CT, pelvis and abdomen. That is, as I told you in the chapter on cervical cancer. CT and MRI are very routinely done investigations now because of the availability, because the cost has come down, and because the surgeons, they want to stage and they want to plan the surgery. So actually, after biopsy, the next thing that they do would be a CT or MRI to check what is the extent of spread. Okay. Pelvis and abdomen for lymph node spread. CT scan is very good for lymph node metastasis. MRI detects soft tissue problems, so it can detect myometrial invasion, and it can help the surgeon in deciding the stage of the cancer. And endocervical spread as well. So soft tissue metastasis is very well picked up with MRI. Then PET scans, they will reveal metabolic activity in the tissue. So PET scans are basically used for diagnosis of the spread of the cancer, and moreover, they generally use for checking the recurrence, or for checking the when you call the patient for follow-up, just to check if it is recurring or it is still localized or it is absolutely gone. So it checks metabolic activity in the tissue, and it is a gold standard for staging. Obviously, if the patient can afford and the facility is available in that particular city, then you can send the patient for PET scan. Okay. Next, coming to the staging. Now, this staging is not as complicated as a cervical cancer staging. It's quite simple. So, clinical staging is generally inaccurate. It is very difficult to stage the cancer just by clinical examination. Okay. FIGO staging, that is the International Federation of Gynecologists and Obstetrician. Staging of carcinoma endometrium was proposed in 2009, and it is based upon endometrial histology, as to what is a histology, and surgical evaluation. Surgical evaluation might be you put a laparoscope inside, or maybe you do a fractional curettage and then you check, or some nowadays CT and MRI are very helpful. Okay, so stage 1 will be the tumor is confined to the body of the uterus. It has not gone down in the cervix, it has not gone out in the fallopian tube or in the peritoneal cavity. So it is just either endometrium or both endometrium and myometrium. Stage 1A will be when myometrial invasion is less than half. Okay, so less than half or absolutely no myometrial invasion. And stage 1B will be more than half of the myometrium is involved, but it has not gone up to the serosa. Stage 2 will be invading the cervical stroma but does not extend beyond the uterus. So because cervix is also a part of uterus, right? So it has gone down into the cervix but still within the uterus and cervix. That is stage 2. Stage 3 is local or regional spread. It can be the pyramitrium, it can be the fallopian tubes. So it is just local and regional. Okay. Stage 3A will be invading the serosa of the corpus uteri and adnexa. So it has invaded the serosa and it has gone out into the adnexa. Stage 3B will be vaginal and parametrial involvement. So parametrial is 3B. So parametrial always comes later because it is considered to be a step higher. Even in the cervical cancer, parametrial involvement is always in the B stage, not A stage. Okay. So A will be just invading the serosa from the fundus and going somewhere in the adnexa, fallopian tube or somewhere. Okay. Stage 3B will be going down into the vagina, especially the lower 1/3, and the parametrial involvement. Then coming to stage 3C, stage 3C has gone into the pelvic and para-aortic lymph nodes. So it has gone up into the higher lymph nodes, that's para-aortic and the pelvic lymph nodes. Now, it is also divided into 1 and 2. C1 will be only pelvic lymph nodes, C2 will be para-aortic lymph nodes. So now we know how the lymph nodes arrangement is there. The aorta has para-aortic, aorta divides into common iliac, then common iliac divides into internal and external on both the sides. So the pelvic lymph nodes are very much in vicinity of the uterus, especially the internal iliac. But when it goes out of the internal and external iliac and reaches up to the common iliac, then it becomes stage 3C2. Okay. Then coming to stage 4, as we know, stage 4 means it is involving other organs as well. So it can be in bladder, it can be bowel, or it can be distant metastasis. Now, when it is stage 4A, it is just bladder and bowel, just like cancer cervix, the adjacent organs are getting involved, and stage 4B will be distant, that is lung, liver, bone, brain. It can metastasize there, okay, and it is always hematogenous spread, right? What can be the differential diagnosis? Well, obviously, when the patient comes with excessive bleeding, DUB, you can't just think of one cancer. It can be cervical cancer, it can be some polyp inside, it can be a fibroid inside, it can be simply dysfunctional uterine bleeding, it can be simply hyperplasia, it can be senile endometritis in postmenopausal women. Sometimes the endometrium might just bleed because of lack of estrogen, it just becomes dry and starts bleeding. It may be tubercular endometritis, some infection, especially tuberculosis, can give this kind of picture. It can be atypical hyperplasia, or it can be polyps, fibroids, or any other pathology, or even adenomyosis. Okay. Now, how do we manage a patient with endometrial cancer? First of all, we have to primarily prevent it. We know the risk factors, so we have to be very careful and try to prevent it. How do we prevent? We tell them to strictly control their weight. Now, weight control is very important, whether it's for infertility, the patient has to ovulate, she's a PCO patient. Even if she's not PCO, she's overweight, she will be prone for hypertension, diabetes, and this can make a corpus cancer syndrome and make her prone for endometrial cancer. Exercise, very important. Strict estrogen use. Now, estradiol use has to be very well monitored. The premenopausal women or the postmenopausal women who have an intact uterus, the uterus has not been removed, just be careful when you give them estrogen. You can give them local creams of estrogen to be applied on the skin, but oral estrogen or even local estrogen in the vagina can sometimes lead to endometrial cancers. Okay, so after menopause, restrict the use of estrogen in non-hysterectomized women, that is, the women who still have a uterus intact. If needed, you can add cyclic progesterone. So in a perimenopausal woman who is still having periods, it's better to add E2 plus P2 together. So you give E2 for 28 days and progesterone for the last 10 days. So you're counteracting the proliferative effect of estrogen, and you're making the patient bleed every month with cyclical estrogen progesterone. But in the case of menopausal women, they are not bleeding. So you cannot induce bleeding in them. They will not accept it. That, okay, why am I bleeding now? I was not bleeding before. So if you give estrogen plus progesterone, then it has to be given not cyclically, but continuously. So they have to take this combination continuously, and many combinations are now available in the market. If you can't get a tablet which has both estrogen and progesterone, you can give them separately. One tablet of estrogen and one tablet of progesterone every day, continuously without any gap. Okay, so that can prevent the proliferative effect of estrogen and can prevent endometrial cancer. Okay, now coming to contraceptions. Contraception OCP use is a high risk for cervical cancer, but it is quite protective for endometrial cancer because it is not letting the intrinsic estrogen to act on the endometrium and cause proliferation, because it is making the cycles anovulatory and it is shutting down the HPO axis. So there is a 50% reduction of endometrial cancer with OCPs, and Mirena coils are also protective. As I told you, you insert a Mirena coil system, which is like a copper T, and it will keep on secreting progesterone, and the endometrium will slowly and gradually dry up because of excessive progesterone. Okay. Smoking is protective. Smoking is a high risk factor for cervical cancer, but it is protective for endometrial cancer. Just the opposite. Education regarding importance of post menopausal bleeding and evaluation. Now, many times women will not come to the doctor. Earlier times they would come only when they have a foul smelling discharge of very bad bleeding or something actually coming out like a cancerous growth. But now I see many women, they're quite aware. They come even if they see 2 drops of blood after say 1 year or 2 years of menopause, they will come running. So they are now very, very aware of all this. Okay. Prophylactic hysterectomy. When do we actually hysterectomize the patient? When do we remove the uterus for no reason? For prophylaxis, we do it in cases where within the family there is a HNPCC syndrome. That means within the relatives there is a syndrome going on. In the males there is a colon cancer, or some female had colon cancer and breast cancer. So these three cancers, they go hand in hand, and there is some suspicion that this is the syndrome running in the family. So you do a prophylactic hysterectomy, and it will prevent 60% of the risk. It will reduce the risk to 60%. Okay, from 60% it will reduce the risk. BSO, that is bilateral salpingo-oophorectomy, reduces ovarian cancer because BRCA gene and HNPCC can be related with ovarian cancer also. So it is a family of cancers which go together. So if you remove the ovary also, you have to tell the patient that you're young, but I'm still removing the ovary because you might develop not endometrial cancer but ovarian cancer later on. So you can remove it and give her HRT. So that is okay. That is acceptable. She doesn't want to end up in a cancer. She can take HRT. Okay. So that is going to reduce the risk of ovarian cancer by 12%. Now, what is secondary prevention? Primary prevention is you are just, before she develops any symptoms, before she actually develops any pathology, you are preventing the cancer. Secondary prevention is you are screening the high risk women now. Okay, screening of the high risk women by annual screening at age after 35 is recommended. Endometrial aspiration and endometrial lavage can be sent for cytology. As I told you, the Pipel forceps, which has a syringe attached, you can just suck out the endometrium by vacuum suction, simply negative suction. You can just pull it out, suck it out, and send it for cytology. If cytology is suspicious, then you have to do biopsy. Okay. Similarly, just like in the breast, if there's a lump, you initially subject the patient for cytology. We do an FNAC, suck out the tissue with negative suction. And then if that is abnormal, then you go for a proper big piece of tissue, that is biopsy. Similarly, in the endometrial cancer, abnormal endometrial curettings in vaginal pool cytology. If there is abnormal endometrial cytology being picked up in the pap smear, sometimes the opposite of the pap spatula. Now, this is a spatula of pap. This one goes inside the cervix, and this is rounded here. So this rounded structure is basically to take a pool, the sample of the vaginal pool, and that's the other end which goes inside the cervix. So this goes inside the cervical canal. That's a cervix here, and this one actually takes scraping from the outer cervix, that is the exocervix. So that's the uterus. So this is how the RS spatula works. This particular end is going. This one is for the endocervical. This is exocervical, and this is sometimes used for the vaginal pool, the shed tissues which are picking up the endometrial, the shed cells, the cells which are lying in the vaginal pool. They may be endometrial, they may be cervical shed cells. So these cells can be picked up and a slide can be prepared in the pap. So if it is abnormal, then you go for a biopsy. Okay, so this is secondary prevention. The patient is already high risk. She's come to you, you're suspecting something, so you do all these investigations. Judicial hysterectomy can be done in pre-malignant lesions. Obviously, when we pick up a pathology like hyperplasia with atypical changes, that is pre-malignant, you can do a judicial hysterectomy. That is advisable. Young patients with atypical endometrial hyperplasia can be given. Now, as I told you, sometimes even atypical hyperplasia, simple hyperplasia with atypical cells can be treated without any surgery because the patient still wants to conceive. She's young, she doesn't want to lose the uterus, or she may be unfit for hysterectomy. So in such patients, you can give norethistone acetate or medroxyprogesterone acetate. The dose is again 30 to 40 milligrams daily for at least 6 to 12 months, and then keep following her with biopsy because you don't want her to end up in cancer. You cannot just leave the patient that, okay, go take the tablet, go with the hormone, and if you are well, don't come back, because the patient will be well. Obviously, she will not have any symptom, but she might be developing cancer inside. So keep the patient for follow-up. And sometimes lifelong follow-up is required for such patients, especially the ones who do not undergo surgery. So they have that focus of uterus inside, which might change into full-blown cancer, and you have to keep them under lifelong follow-up. Okay. Now coming to proper curative treatment for endometrial cancer. Pre-treatment workup, what do? We do all the blood tests before we actually subject the patient for surgery or radiotherapy or chemotherapy. We do a complete blood count, we do blood sugar, renal function test, liver function test, we do serum electrolytes, because whatever correction we have to make, it has to be before surgery. After surgery, the patient will be having lots of morbidity, and that can add on to her morbidity if this was not detected properly. Even ECG to check the status of the heart. Then urine complete test, so that if there is any infection, then you can check. ECG, yes. Chest X-ray to check if there is lung pathology. Even though there is no metastasis, any patient undergoing surgery, her chest X-ray should be done so that we know what is the status of her lungs. Sonography, abdomen and pelvis, obviously. MRI and CT, yes, in any cases of cancer, now MRI and CT, or MRI or CT, not both, depending upon what we are suspecting. Sometimes both are required, one for the lymph node, one for the soft tissue. So we need this, and it is quite easily available these days. All right. Next, coming to the treatment modalities, what treatment modalities do we have? Just like any other cancer, it is surgery, radiotherapy, chemotherapy, and one more thing, that is hormonal therapy, because it is endometrial cancer, so it can respond to hormones as well. Okay, so surgery will be laparotomy, that means you open the abdomen. Laparoscopy means you put a keyhole surgery, you use these kind of instruments, thin instruments, you go there, you do not give a big incision, go inside with the laparoscope, do the surgery, and that has to be done by a trained surgeon who knows what to do. Okay, and it can be robotic surgery, very much in fashion now. Few hospitals all over India, they are having robotic surgeons. Robots are performing the surgery, and the surgeon is manipulating. It is like a video game. You are manipulating your robot. You are just sitting on the panel, and you are playing with your buttons, and your robot is operating. So that is a very good surgery, because robot knows if it has been marked by the surgeon that you have to remove 2 centimeters of the tissue, the robot will remove 2 centimeters only. Okay, because robot is acting better than a human, because it's a computer. Okay, so robotic surgery is laparotomy and laparoscopy. Chemotherapy can be Taxol, it can be adriamycin, cisplatin, carboplatin, and paclitaxel. As we read in cervical cancer, cisplatin is a radiosensitizer, so it increases the radiosensitivity of the squamous cells for radiation therapy. But in cases of endometrial cancer, it is actually a chemotherapeutic agent which has been used for curing. So cisplatin, carboplatin, adriamycin, Taxol, and paclitaxel. Okay, remember that. Radiation therapy can be external beam, which has to be given externally, or it can be intracavitary. You can put it inside the uterus, or you can put it in the vagina, intravaginal, just like in cervical cancer. Hormonal therapy, because it is endometrial cancer which has receptors for estrogen and progesterone. You can use progesterone or tamoxifen, because these are the hormones which will reduce the proliferation. They're anti-estrogenic, and sometimes combined therapies of hormone, chemo, and maybe surgery. So it all depends what kind of cancer it is, and depends upon the surgeon's choice as well. Now, in general, stage 1A, that is limited to the uterine corpus and less than 50% of the myometrium involved. Grade 1, you normally do a simple hysterectomy with bilateral salpingo oophorectomy. No lymph node dissection is required. It is just contained within the endometrium and just a little bit invasion into the myometrium, and it is grade 1. When it becomes grade 2 or grade 3, that is 50% or more than 50% are not well differentiated, and they are kind of losing the glandular architecture. Even in stage 1A, you go for simple hysterectomy, but lymph node dissection has to be done, and these are pelvic as well as para-aortic. Okay, plus minus, you may think of post-operative radiotherapy. That will depend upon the biochemical markers, as I told you, whether it is type 1 or type 2. All these markers will be studied by the pathologist, and the oncosurgeon will decide whether after surgery they need radiotherapy or not. Then coming to stage 1B, that is, it has involved more than 50% of the myometrium. Now it will be again simple hysterectomy, because it has not gone out, but it will need lymph node dissection. Yes, definitely. Whether it is grade 1, 2, or 3, it will definitely need lymph node dissection, para-aortic and pelvic. Plus minus, again, it depends whether the radiotherapy has to be given or not. So irrespective of the grade 1, 2, or 3, stage 1B, when more than 50% of the myometrium is involved, you have to give you have to go for lymph node dissection with simple hysterectomy, plus minus post-op radiotherapy. Then coming to stage 2. Stage 2 means it has come down to the cervix, but still within the uterus. It has not invaded into the parametrium. Even then, simple hysterectomy doesn't have a role. Now we do radical hysterectomy. For times we are removing the parametrium as well. We are doing omentectomy, because it might be invading into the omentum. There may be micro spread through the lymphatics. Then lymph node dissection, yes, it has already been suggested to do in stage 1B. So stage 2 definitely needs para-aortic and pelvic lymph node dissection. Vardyne cystectomy with post-operative radiotherapy is another option. Now, radiotherapy can be 4 to 6 weeks after surgery. Obviously, the surgeon will decide the surgery once it is healed, once everything is fine, then you subject the patient for radiotherapy. How many cycles of radiotherapy, that will be decided by the oncologist. Radiation can be external, because now the uterus is removed. It can be external beam, or it can be intravaginal, but if you are doing it before surgery, then it can be inserted into the cavity, that is intracavitary. Then followed by surgery, simple hysterectomy. So if you have done radiotherapy before and now you're going for surgery, then you can just simply do total abdominal hysterectomy with bilateral salpingo-oophorectomy after 6 weeks. So it can be either surgery first and later on 6 weeks later you give radiotherapy, or it can be radiotherapy first, 6 weeks later you can do simple hysterectomy. So that depends upon the surgeon's choice and the type of cancer. Stage 3 and stage 4, where the cancer has come down to the vagina, it has gone to the lymph nodes, it has gone to the parametrium, and now stage 4 invading into the bladder, the distant metastasis, bowel. So now you have to just do debulking surgery because it has invaded outside. Debulking as to how much you can remove, do para-aortic and pelvic lymph node dissection, plus minus depending upon radiotherapy or chemotherapy. I would say yes, there will be a radiotherapy or chemotherapy. It will actually be plus Y plus minus. Stage 3 and stage 4 should actually have post-operative radiotherapy and chemotherapy. Okay. All kinds of serous, clear cell, and adenosquamous carcinomas. These are the high risk cancers which are generally very rarely seen, but they can be the type of cancers which are very, very dangerous. Yes, it is not an endometrioid, which is 80% chances. 1 or 2% or maybe 5% maybe serous, clear cell, or adenosquamous. They will definitely need total abdominal hysterectomy with bilateral salpingo-oophorectomy, definitely lymph node dissection, and plus minus radiotherapy, irrespective of what stage they are in. So they will not be categorized into stage 1A, 1B, 2, 3, and 4. Okay, so these are the very invasive ones, and they will need hysterectomy with radiotherapy with lymph node dissection. Now, coming to the hormonal therapy is used in endometrial cancers and even in breast cancers because these are the tissues which are responsive to hormones. So, progestogen is it gives a good response in well differentiated ones, that is grade 1 carcinoma with adequate receptors. The receptors have to be there, estrogen and progesterone receptors. If they are there, then only the progesterone can act. And remember, progesterone always acts on the endometrium which has been primed with estrogen. So both the receptors have to be present. Now, what are the options? It can be medroxyprogesterone acetate in the form of tablet, which is 30 to 40 milligrams, or it can be in the form of injection, which is DMPA. Why DMPA? Depot medroxyprogesterone acetate. Depot means it is a big dose that you're giving as a depot, which is going to stay there for 3 months. So it is a one single shot injection, stays for 3 months, and then you repeat it. Okay? So it is not a daily tablet or daily injection. MPA, then magistrol acetate is another option. Then NET-N, that is norethistone acetate. 3 to 6 months you give them. Another entity is 17-hydroxycaproate. Generally, in practice, it is MPA and NET-N, which is commonly used. Norethistone acetate has been shown to have a stronger effect as compared to medroxyprogesterone acetate because it suppresses the estrogen receptors as well. Tamoxifen, as I told you, it is a hormone which has anti-estrogenic as well as estrogenic properties. So it is basically given to women who have undergone breast surgery, breast cancer surgery, and if it is given for long term, the endometrial biopsy has to be taken because it predisposes the patient for endometrial cancer. But similarly, it has also been used for as a treatment because it has both anti-estrogenic as well as estrogenic properties. So non-steroidal anti-estrogenic plus weakly estrogenic. So it is a precursor for cancer and it has been used for treatment also. So if it is given 10 milligrams twice a day along with progesterone. Probably the anti-estrogenic effect is there for some time, but if it is continuously given and in high doses, it can lead to cancer. Okay, so it has both the effects. What are the prognostic factors? How the treatment works? Age, if they are older, we have read it is generally type 2, they have a poor prognosis. Staging, yes, we know stage will define the prognosis. Histological type, papillary, serous, clear cell are very, very invasive. Adenoacanthoma is very invasive. Histological differentiation, grade 1, grade 2, grade 3, 2 and 3 are very, very invasive, especially 3. Histological grade, myometrial penetration, yes, definitely. Lymphovascular space invasion and lymph node metastasis that will decide the prognosis. Extension to the cervix, that is stage 2, and peritoneal cytology. These are all prognostic factors, some related to age, some related to histological differentiation, some related to the type of cancer it is, and generally related to the staging. Okay. Other factors which decide the prognosis are peritoneal cytology. We know that, yes, peritoneal cytology will definitely show, will actually point towards the kind of stage it is, how much it has invaded. Tumor size more than 2 centimeters, then more lymph nodes will be involved. Okay, size is also there, although in the staging there is no mention of the size. Hormone receptors, if they are present, then it is a good status, it is a good prognosis. Ploidy status, we know that it is aneuploid in type 2 and that has a bad prognosis. Polyploidy is better. Oncogene expressions, if HER2 and NEU are expressed, especially we know in type 2 that it's a poor prognosis. Type 2 endometrial carcinoma is poor prognosis. We know all these points are going hand in hand with type 2. And 5-year survival rate. If you look at this chart, it is 80 to 90% in stage 1 because it is just the corpus of the uterus which is involved. Stage 2 is involving the cervix. Still, it is a good prognosis of 75%. 5-year survival rate. Now, once it goes out of the uterus, the survival rate drops down to 30 in stage 3, and stage 4 is only 10%. But the good thing in endometrial cancer is they present quite early. Okay. There is another entity which you should know, the recurrent disease. Recurrent cervical cancer, recurrent endometrial cancer. Obviously, if anything is recurring, the prognosis goes down. So within 2 years, 50% will recur, and within 3 years, 75% recurrence will be there. Common sites will be vagina and pelvis. Once the uterus has been removed, the vault metastasis is very common, and pelvis, if the micrometastasis was there, now they will start developing cancer there in the pelvic lymph nodes or the parametry. Extrapelvic can be sometimes lungs, paraortic lymph nodes, liver, brain, and bone. So these are the secondary metastases. Maybe it was stage 4, it went undiagnosed, and there was some lesion which started growing now. Radiation treatment is the one which is preferred because obviously mostly the surgery has been done. So radiation can be done for isolated recurrence following surgery. Exenteration surgery is not much of use. What is the exenteration? Basically, you remove the entire pelvic organs. You remove bladder, you open the urine opening onto the abdominal wall, you remove the rectum because it is getting involved. So you open the colon on the abdomen. So that is exenteration. You clear the entire pelvis, remove everything. Now that is not much of use in cases of recurrent endometrial cancer. Hormonal therapy and chemotherapy may have a role. So it is radiation, hormonal, and chemotherapy, not much role of any kind of surgery in recurrent disease. How do you follow a patient with recurrent disease? Once she has come with recurrent disease, 50% within 2 years, 75% within 3 years. Now you have given her initially whatever, chemotherapy, radiotherapy, depending upon where the metastasis was there, where the recurrence has happened, pelvis or lungs or liver. You give her the treatment and then you keep her for lifelong follow-up. So how do you follow her up? In the initial 4 months, initial 2 years, you follow her up every 4 months. Every 4 months you call her and you check, and then in the next 3 years you call her annually, that is every 6 months, and after that every year once she has to come lifelong. And what do you actually check when she comes? Because you are suspecting recurrence, you have to check for chest x-ray, you have to ask her any signs and symptoms suggestive of recurrence. Then mammography, it might go into the breast. You have to do a CT, MRI, or even PET scans are very, very useful. And CA125 is an indication that, okay, maybe the cancer is coming back. Okay. So what did we actually discuss in this chapter? We discussed what are the etiological and risk factors for endometrial cancer. It is generally estrogen stimulation, especially in the premenopausal group, and that is a type 1 carcinoma. Type 2 has no relation with estrogen. Okay. Then early menarche, late menopause, again to do with estrogen. Low parity, again to do with estrogen. Very few episodes of amenorrhea. Corpus cancer syndrome, obesity, hypertension, diabetes. Tamoxifen, history of tamoxifen continuously for breast cancer or any other reason. Family history suggesting towards HNPCC syndrome. Classification will be based upon histological and biological behavior. So it is type 1 and type 2. Based upon differentiation, glandular architecture, and anaplasia of the cell, that is grade 1, grade 2, and grade 3. Then staging has been given, put forward by FIGO, that is stage 1, 2, 3, and 4. Spread is generally direct and lymphatic. Hematogenesis always late when it comes to stage 4. Diagnosis gold standard is endometrial biopsy, which can be done by fractional curettage, taking curettings from different parts of the uterus and endocervical and labeling them separately in the jars. Then treatment will be obviously laparotomy. Generally, it is done with full opening the abdomen and doing the surgery. Some trained surgeons will be doing it laparoscopically or robotic surgery. Chemotherapy, you have to remember the chemotherapeutic agents. That is, 2 C's are there: cisplatin and carboplatin, Taxol, then adriamycin and paclitaxel. You can make a mnemonic for yourself. Radiation therapy, again for uterus, it can be always whether it's cervical cancer or it is uterine cancer. It can be intracavitary inside the uterus, it can be intravaginal, or it can be external beam. You mark the area and then give external beam radiotherapy. Hormonal therapy, progesterone and tamoxifen, they do well, and combined therapy can be suggested in such cases. So that is all, children, you need to know about endometrial cancer, a cancer which is third in the leading causes of death in India, and it is just next to the cervical cancer because it presents earlier. So that is why the treatment is much easier and the mortality rate is less.